Well, thank you very much for your very nice introduction and invitation again to be here. And for this morning to talk about a topic very near and dear to me, and that is the topic of omitting regional nodal radiation in responders to neoadjuvant chemotherapy, and in that also discuss the NSABP B-51 RTOG 1304 trial. So we know that neoadjuvant chemotherapy was originally utilized to convert patients with inoperable, locally advanced breast cancer to surgical candidates. And eventually, as we started to utilize this more in patients with operable breast cancer, randomized clinical trials comparing preoperative to standard adjuvant chemotherapy showed similar results. So, of course, one can say, well, if the results are similar, why do neoadjuvant chemotherapy? But on the other hand, you can also say, if the results are similar, what are some of the advantages of using neoadjuvant chemotherapy? And so with that in mind, there are several clinical advantages that we'll discuss. Neoadjuvant chemotherapy became actually a reasonable alternative to adjuvant chemotherapy for those patients with large operable disease that required some downstaging for surgery. And again, as I said, neoadjuvant chemotherapy offers several potential clinical advantages over adjuvant chemotherapy, and I underscore here, inappropriate candidates. And I think that is the key to identify the patients that benefit the most from neoadjuvant chemotherapy. And we'll talk a little bit later today about neoadjuvant chemotherapy and genomic profiling for patients with ER-positive, HER2-negative disease. And as you know, for over the several decades of using neoadjuvant chemotherapy, the important endpoint for neoadjuvant chemotherapy is the achievement of pathologic complete response, essentially the elimination of the invasive disease in the breast as well as in the axilla. So we have known that patients that achieve a pathologic complete response after neoadjuvant chemotherapy have significantly better outcomes than those that do not. And as a result, PCR has become a surrogate endpoint for neoadjuvant chemotherapy efficacy, and in fact, pathologic complete response along with event-free survival have been utilized for accelerated approval of new agents, namely pertuzumab in 2013 for the neoadjuvant treatment of breast cancer. Now, we also know that pathologic complete response varies according to tumor subtypes. These are results from a meta-analysis by Pat Cortazar showing that patients with estrogen receptor, hormone receptor positive and HER2 negative disease had much lower rates of pathologic complete response compared to the triple negative patients and to HER2 positive patients here in the middle. And of course, these are with treatments that were used back in the days when these clinical trials were conducted. These are not the best treatments that we have today. And this is reflected to some extent in HER2 positive patients when we see with the addition of trastuzumab in some of the trials, we see almost a doubling of pathologic response to the hormone receptor positive HER2 positive patients, and also another 20% increase in pathologic response in the hormone receptor negative HER2 positive patients. So what you actually can see here is that for hormone receptor positive HER2 positive patients that did not receive trastuzumab, the rates of pathologic response were very similar to the high-grade hormone receptor positive HER2 negative patients, and even those in hormone receptor negative HER2 positive without trastuzumab are very similar to the triple negative patients. But you see, for example, the advantage of using anti-HER therapy here. But again, this is in the past because nowadays we have much higher pathologic complete response rates, in particularly for patients with triple negative and HER2 positive disease. So this is sort of a historic overview of the low pathologic response range when we started the neoadjuvant chemotherapy with the CMF-based therapy, almost 7 to 8%. Double that when anthracyclines were introduced. You even double that when the taxanes was introduced. I thought, of course, this was independent of subtypes, But then, when we focus more in the HER2-positive patients, with single anti-HER therapy went up to 40 to 45%, double anti-HER therapy, double agent, 55 to 60%. And on the right side here, triple-negative breast cancer, which is a very tough cancer to treat, as you know, with aggressive behavior, we have gone down to now a PCR rate of about 50 to 55% when anthracycline taxane-based regimen plus carboplatin was used. And then when we have also the addition of pembrolizumab, the pathological complete response rates went up to 65%. And I'm showing you this to tell you that I think our medical oncology colleagues have made significant efforts and progress in treating this disease. And of course, this is now upon the locoregional therapists to take this data and actually see if we can customize the locoregional therapy, and we'll talk a little bit more about that. So how can we maximize the clinical impact of neoadjuvant chemotherapy? Well, obviously, as I mentioned, developing more active drugs and regimens and apply them as neoadjuvant therapy will improve on the efficacy and potentially on the downstaging of patients with better outcomes depending on the surgical radiation therapy. Also, we can try to identify better predictors of pathological complete response so we can better select patients that are more or less likely to benefit from neoadjuvant chemotherapy. And one can do this either with baseline biomarkers or with early changes in biomarkers with neoadjuvant chemotherapy. And there's several studies now that are looking at the intermediate biomarkers, either MRI response or PET-CT response during neoadjuvant chemotherapy. And we'll talk a little bit more for the ER-positive patients later on, for example, with drop in the Ki-67 as an intermediate biomarker. We can then use pathological complete response and EFS for accelerated drug approval. We probably maxed out on that because now the pathological response rates are so high that incrementally you need a lot more effort to actually approve a new drug, going from 65% to late 70 or 80%. And of course, use primary tumor response to individualize locoregional as well as systemic therapy. And this talk will focus on the locoregional therapy, but of course, systemic therapy is another very important component of this, where you can then customize the post-neoadjuvant therapy, systemic therapy, based on whether you achieve the PCR or not. And there's a lot of research on that, as you know. So what we have achieved so far, and this is a brief overview here, we have converted inoperable patients to operable candidates. We have converted mastectomy candidates to breast conservation candidates. And we have shown that you reduce the extent of axillary surgery by downstaging involved axillary nodes and then converting patients from axillary lymph node dissection to sentinel lymph node biopsy with or without targeted dissection. And we'll talk a little bit about that today because it's difficult to talk about the regional radiotherapy and not talk about the surgical management of the axilla because they go hand in hand. And of course, the last topic, reduce the use and extent of locoregional radiation, but downstage in primary tumors and involve axillary nodes. So what I'll do today, I'll focus my comments on the last two topics here, the surgical management of the axilla after neoadjuvant chemotherapy and the use of regional nodal radiotherapy or omission of. When it comes to the axilla, early randomized clinical trials that compared neoadjuvant to adjuvant chemotherapy showed clearly you can downstage about 30 to 40% of positive axillary nodes. Trials like the NSABP B-51, the ORTC trial, and then even trials later on, the ECTO trial and B-27 showed further downstaging. But nowadays, with a new and effective therapies that I showed you earlier, about 50 to 75% of axillary downstaging is expected, particularly for patients with triple-negative and HER2-positive breast cancer. And of course, that has significant potential for decreasing the extent of axillary surgery with sentinel lymph node biopsy. Now, when it comes to decrease the extent of axillary surgery, it's fair to say that this concept so far is applicable mostly for patients with operable breast cancer, with clinical T1, T3, clinical N0, clinical N1. Perhaps you can delve into clinical N2, although not many patients were included in these trials. The feasibility and accuracy of sentinel lymph node biopsy after neoadjuvant chemotherapy is questionable for patients with locally advanced breast cancer, T4 disease, clinical and 2 inflammatory breast cancer. Now, this may change as we apply targeted axillary dissection. We may make and as I will show you, the false negative rate much lower, and perhaps we can apply this in the future for patients with more locally advanced breast cancer. Another tool that has helped us in this quest of decreasing the axillary management, the surgical management, is the ultrasound of the axilla with fine needle aspiration or core biopsy of indeterminate suspicious lymph nodes. As you know, this is a very simple, minimally invasive technique, and it can provide us with useful clinical information. For example, if we see abnormal lymph nodes who biopsy and they're positive, you can avoid a sentinel lymph node biopsy if you were to do surgery up front and move to axillary dissection without any further doing sentinel lymph node biopsy. You can mark the lymph node that is positive in that case and demonstrate direct chemosensitivity of the node that was positive to now have become negative, and then help us in future removal of that lymph node. Now, the sensitivity is relatively low. The specificity obviously is very high, 100%, but the sensitivity is higher if the size of metastasis is over 5 millimeters. It's very low when it's less than 5 millimeters. It's about 44%, as you can see here in some studies, but it can be up to 93% if the metastasis is real, like 5 millimeters or more. So how do we manage patients that present with clinically negative axilla and are about to undergo neoadjuvant chemotherapy? Well, there was a lot of debate over the years. Should we do the sentinel node up front to make sure that it's negative or positive, and then we do the neoadjuvant chemotherapy? But when you do that, you remove the node that has potentially the disease, so then you lose the ability to tell if that lymph node is downstage. So after a lot of debate, do it before or do it after neoadjuvant chemotherapy, the camp that is doing it after neoadjuvant chemotherapy has won. And the reason for that is that you capitalize on the downstage effect of neoadjuvant chemotherapy. You need to see the node to make sure that it becomes negative. And of course, randomized trials eventually showed that the performance characteristics of the sentinel lymph node biopsy in this setting, clinical and 0 patients, are as good as if you did surgery up front. You can see the false negative rate is low, and the identification rate is very high in this meta-analysis. So this is pretty much how we handle the clinically negative axilla for patients that we give neoadjuvant chemotherapy. But what about patients that have documented involvement? The nodes are abnormal by ultrasound or they're palpable. You do a fine needle aspiration or core biopsy, and the node's now positive. Is it safe to de-escalate axillary surgery and omit axillary dissection turn to sentinel lymph node biopsy? Well, we have a lot of data for this in several prospective trials. As you can see, the Z1071, the Sentina, the Canadian SNF and AC trial, and the Ghanea-2 trial. And all these trials essentially aimed to see if the false negative rate in this situation will be about 10%. But if you see there, the false negative rate was a little higher. It was about 12, 14% in one trial. The Canadian was 8.4%, but that's because in that trial they actually used immunohistochemistry in the sentinel node that improved the sensitivity, but even in the French trial was about 12%. So we felt that this is a little too high, and can we identify ways of making it a little lower? And one of the ways was to do dual mapping, but the other way was to remove 2 or 3 or more sentinel lymph nodes, because consistently these trials have shown that the more sentinel lymph nodes you remove, the less the false negative rate. And it can drop to high single digits, as you can see, with 3 nodes or 2 nodes in some of these trials. So this was better, but maybe we could have done better as well. And one observation from initially the 1071 trial was that when they did the sentinel lymph node biopsy and then followed by an axillary dissection, in all these trials, that's what they did. They did sentinel lymph node biopsy followed by an axillary dissection so they can do the false negative rate. They found that if you the clip that you used to biopsy the lymph node, if it was included in the sentinel lymph node biopsy specimen, the false negative rate in 1071 dropped from the 12.6% to 6.8%. But if the clip was found in the axillary dissection specimen, not in the sentinel lymph node biopsy specimen, then the false negative rate was 19%. So one of the first demonstrations that having the clip within the sentinel lymph node biopsy specimen is important. And of course, then we had this experience from MD Anderson that took patients again with positive nodes, biopsy proven, and they did sentinel lymph node biopsy and axillary dissection. And then they counted either the clipped node or the sentinel nodes or both. And when they counted the sentinel node alone, then the false negative rate was about 10%, which is what we have expected. But when they just counted the clip node and say what would be the false negative rate just by knowing what the clip node shows, then the false negative rate dropped to 4.2%. And then if they said, well, now if we count the sentinel lymph node and the clip node as the important nodes, what would the false negative rate be? And it was about 1.4%. So remarkable progress if you look at that in terms of the false negative rate. And why is that? Well, that is because consistently in this trial and many other trials, it was shown that when you have a previously biopsy node, the clip node, when you do the sentinel lymph node mapping and biopsy, in about a quarter of the patients, that lymph node does not qualify as a sentinel node because it is scarred from having tumor there and respond, and the lymphatic system bypasses it and goes to other lymph nodes. So identifying that lymph node and removing it increases our ability to rightly call what the lymph node status is. And this has now been proven in a prospective trial. This is the RESAS trial from the Netherlands. Now, the Dutch for years have done a different approach. They have injected radioactive iodine in the node that was positive before, and that stays there for a long time. And then they were able to remove this node, and they called this node the MARI node, the radioactive iodine node. And when they did that, they saw about a 7% false negative rate, as you can see here in the bottom. So they asked the question, if we do the MARI node, we take the node that was biopsied before, and now we also do the sentinel lymph node biopsy in the lymphatic mapping, what would the false negative rate be? And that was the RESAS trial, and they found that the false negative rate dropped to 3.47%. That's an important observation, I think, to know that you improve on the ability to characterize the lymph nodes by removing the clipped node. And of course, nowadays we have several wireless systems to localize the lymph nodes as well as in the breast, of course. We can use radioactive seeds, the Saviscout magnetic seeds, and even carbon injection in the nodes if you don't have this ability. But certainly with that technology, we pretty much can identify always the node that was biopsied before and has the clip. So that's how we typically do. Now, some argue that maybe you don't need to go to that extent. Maybe 2 to 3 nodes removed gets you in a low false negative rate, and you don't have to go through this localization and removal. But I argue that even in those situations, the false negative rate was upwards of 7–8%. With a clip node, it's dropped down to 2 to 3%. It's much better, and I'll explain to you why. Now, the arguments that those that don't want to do the clip node use is like, well, the false negative rate is one thing, but the axillary recurrence rate is so low in these patients that whether you remove the clip node or not, it probably won't make a big difference. And this is true because, as you can see, axillary recurrence in many series, this is the older series, some prospective, some retrospective, different follow-up, some of them very short, but some long-term follow-up. And you can see the axillary recurrence rate, single digits, even less than 1% sometimes. The highest is like 2.3%, very, very low. And then more recent experience, including the targeted dissection, they show also a very low rate of axillary recurrence. You can see almost all of them less than 1%, with one exception here with a single tracker in the Assan Center. So they say, well, if the recurrence rate is so low, why bother with all this? Well, my argument is that it's not so much the recurrence rate that it makes it important to get it right. It is because we need to know exactly if the nodes are negative or positive after neoadjuvant chemotherapy. And even when they talk about comparing TAD, the targeted axillary dissection, to sentinel lymph node biopsy, the local recurrence rate, as you can see in this retrospective study, was actually very low. It was less than 1% for both arms. But the argument is that knowing the correct status of these nodes has implications in terms of what we're going to do afterwards. Of course, accurate assessment of presence or absence of residual disease is important because, as we will discuss, it can dictate appropriate use of post-mastectomy radiotherapy and regional node radiotherapy. But perhaps more importantly, it can dictate appropriate post-neoadjuvant systemic therapy, because now we have strong evidence that capecitabine, for example, for triple-negative breast cancer, improves overall survival. T-DM1 in HER2-positive breast cancer improves overall survival. Abemaciclib, as you heard earlier today, the CDK4/6 inhibitor, improves outcomes. And in fact, even now, abemaciclib improves survival in the adjuvant setting. It was just released on a press release yesterday from the Monarchy trial. And of course, olaparib was shown to improve survival in BRCA-positive patients that undergo neoadjuvant chemotherapy and have residual disease. So all these are very important. Now, of course, some of those are for patients that have residual disease, but sometimes you may have residual disease in the breast, but sometimes you may not have residual disease in the breast, maybe disease in the axilla. So it's important to get it right. In addition, several clinical trials are currently evaluate adjuvant therapy, either escalation or de-escalation based on pathologic response in the breast and lymph nodes. So accuracy, I think, matters not only for local control and what we do after, but also for systemic therapy decisions. Now, very briefly, what do you do if after all this, the sentinel lymph node is still positive? Well, the standard then is to do an axillary lymph node dissection, because several studies have shown that the non-sentinel lymph node positivity rate is pretty high, 60 to 70%. And of course, this is true not only, I will show you in a minute, not only if you have macrometastasis in the sentinel node, but also if you have micrometastasis. Even with micrometastasis, you have a pretty high rate of non-sentinel lymph node biopsy positivity. This may not be the case for isolated tumor cells, but we'll discuss that in a minute. Going back, though, sorry about that, let me go back. So this is a trial from Alliance that actually will answer the question. This is a trial for patients that have positive nodes before, they go to neoadjuvant chemotherapy, and the nodes, the sentinel nodes are still positive, and then the randomization is to completion axillary dissection or not. This trial has been completed accrual now for several years, and we hope that in the next year or two, 2026, we should be able to hear the results of the study. And obviously, if that doesn't show a difference, then we can omit doing an axillary dissection even for that group of patients. Of course, in that trial, everybody receives post-mastectomy and regional nodal radiotherapy because the nodes are still positive. So I'll skip through these. So for isolated tumor cells, there is some debate because the non-sentinel lymph node positivity rate is fairly low. This is a prospective study, not randomized, but prospective collection of data, showing that about 30% of the patients that had isolated tumor cells in the sentinel node had disease in the non-sentinel nodes, but the majority of those, about 18%, had more isolated tumor cells. Only 12% had macro or micrometastasis, and of course, the local recurrence was very low, whether you had an axillary dissection for those patients or not. Now, ITCs are not very common, and we'll talk a little bit about that relative to the B-51 trial. But again, for these patients, perhaps we can omit axillary dissection at this point. So now to the topic that really we needed to talk about, and is the topic of can we tailor regional nodal radiotherapy for patients who convert to YPN0 after neoadjuvant chemotherapy and patients that had positive nodes before, biopsy proven. And the crux of the argument here is that for patients that have positive nodes and get upfront surgery. There's ample data to show that post-mastectomy and regional node radiotherapy makes a difference, and I'll show you some of the curves next. But patients that have positive nodes go through neoadjuvant chemotherapy and then become pathologically node-negative have been shown, and I'll show you some data, they have lower local recurrence rates than those that were node positive and remained positive. So the big question here is, do such patients benefit from regional nodal radiation? In other words, should we treat these patients as node positive that they were before neoadjuvant chemotherapy, or as node negative after neoadjuvant chemotherapy? These are the data for post-mastectomy radiotherapy, the last overview analysis, showing that even for 1 to 3 positive nodes, as well as 4 or more positive nodes, there is a big difference in local recurrence with radiotherapy, as well as in any recurrence and breast cancer mortality. So clearly you gain from these patients. Now, this has been sort of criticized a little bit because these rates are pretty high for 1 to 3 positive nodes without radiotherapy, almost 20%. That's a pretty high rate. Nowadays we have much lower. But even in more modern radiotherapy trials, such as the MA20, looking at the effect of regional nodal radiation after breast conservation and breast radiation, you can see there is improvement in disease-free survival, isolated local recurrence, and distant disease-free survival, a very small trend also for overall survival. And then in the EORTC 22922 trial that looked at RNI, regional nodal radiation after PMRT or breast radiotherapy, there was still an improvement in distant disease-free survival with a trend in overall survival. So this is real for node-positive patients, but the same meta-analysis and other studies have shown that node-negative patients don't seem to benefit from regional nodal radiation. There's no need for that. So as far as the neoadjuvant experience and what happens to patients that get neoadjuvant therapy and then go to surgery, we did a combined analysis of 2 NSABP studies trying to identify independent predictors of locoregional recurrence and also to identify rates of locoregional recurrence. So between the neoadjuvant group from the B-18 study, this was surgery first followed by HC or AC followed by surgery, so we took this group. And then in B-27, we had 3 groups of patients that received neoadjuvant chemotherapy. We combined this to a cohort of 3,000 patients with 356 locoregional recurrences as first events. And where we identified independent predictors that were a little bit different for patients that had lumpectomy and those that had mastectomy. So for lumpectomy patients, the age of the patient was an independent predictor, clinical nodal status was an independent predictor, as well as a combination of pathologic response in the breast and in the axilla. So as you can see here, a clinically node-positive patient would have very high rate of local recurrence if it remained pathologic node-positive. If it became node-negative but had disease in the breast, they did better, and if they were node-negative and have pathologic complete response in the breast, the rates dropped even further. And this was even better for clinically node-negative patients, but you can see the same trend. For mastectomy patients, age was not an independent predictor, but tumor size was an independent predictor. In the same way, you can see that clinically, for example, node-positive patients, tumor size goes here, very high rate of local recurrence if they remain node-positive, less if they became node-negative but had disease in the breast, and even less if they had pathologic response in the breast and nodes. And here you can see a rate of about 5% or so, and this is for clinically node-positive patients. So this data and some other data from small retrospective studies provided the rationale to move forward and look at the B-51 study, that the schema I'm showing you here. So this study took patients with clinical T1, T3, clinical N1, M0 breast cancer, and important to emphasize clinical N1, which means palpable lymph nodes, abnormal or by ultrasound, not matted. N2 disease clinical means the nodes are matted. And there was a little error in the publication and it mentioned 1 to 3 positive nodes because the journal decided to editorialize and we didn't pick it up. But that's not the case. So patients in B-51 could have had, if they had an ultrasound, they saw 4 or 5 abnormal nodes, that was okay. They could come in, as long as they were clinically not matted. And of course, they had to have biopsy of the nodes and then receive neoadjuvant chemotherapy plus anti-HER therapy if they were HER2 positive. And then after they were stratified, let me go back. After they were stratified, they were randomized to either no regional nodal radiation or regional nodal radiation. Now, what that meant was that if patients had a breast conserving surgery, they all got breast radiotherapy, but if they were in this group, they only got the breast radiotherapy. If they were in this group, they also had the regional nodal radiotherapy. If patients had mastectomy and they were randomized to this group, they received nothing. No chest wall radiotherapy, no regional nodal radiotherapy. In this group, they received both chest wall radiotherapy and regional nodal radiotherapy, right? So the primary objective of the study is to see whether the addition of regional nodal radiotherapy improves invasive breast cancer recurrence-free interval, and what that means is time from randomization until an invasive local, regional, or distal recurrence or breast cancer death. Secondary objectives was local regional recurrence-free interval, distal recurrence-free interval, disease-free survival, overall survival, and toxicity. Now, the study was designed to have about an 80% power to detect a 35% reduction in IBCR-FI, which would equate to about 4.6% absolute difference in the 5-year rate. Now, the final analysis was supposed to happen after 172 events or 10 years after study initiation. And at San Antonio in 2023, we presented a time-driven analysis because we weren't at the 172 events, but we were 10 years from the first patient entering the study. So we randomized 1,641 patients, 1,602 were analyzed for survival, and 1,556 were analyzed for other disease-related endpoints. So in the no-RNI group, 734 patients, RNI 772, and the median follow-up was 59.5 months, so essentially 5 years. And as you know now, the results have been published at the New England Journal this year, earlier. So when you look at the baseline characteristics, and I won't spend too much time on that, but again, for example, age was represented. Younger patients were included, less than 40 years of age, about 40%, as you can see. Race, African Americans were overrepresented, 17-18%, due to the fact that they get a lot more triple-negative breast cancer, and they were included. Clinical tumor size, about T2 in about 59-60% were T2. There were some T3s as well, about 20%. In terms of tumor subtype, about a quarter of the patients was in each subtype. For example, about 20% were triple-negative, 22%. ER-positive, HER2-negative, about 20%. ER-negative, HER2-positive, about 25%. And ER-positive, HER2-positive, about 30%. So overall, the HER2-positive subtype was about half of the study. And that's reflective of the fact that those patients get more commonly pathologic complete response. Breast surgery was lumpectomy, 58%, but mastectomy, 42%. Axillary surgery, sentinel lymph node biopsy was included 55% of the times. We amended the study at some point to include that 2 or more sentinel nodes needed to be removed when we got the results from the Alliance trial, the ACOSOC trial. But also, axillary dissection was about 45%. And then we allowed patients to have PCR or no PCR in the breast, and about 22% of the patients still had disease in the breast but had sterilized their axillary lymph nodes. So this is the primary endpoint of invasive breast cancer recurrence-free interval. And as you can see, there is no significant difference between the two groups. The hazard ratio is 0.88. The absolute difference at 5 years is 0.9%, less than 1%. So no difference in the primary endpoint. There were no differences in any of the secondary endpoints. We see here local regional recurrence-free interval, distal recurrence-free interval, disease-free, and overall survival. You can see that practically the curves are superimposable. None of the difference is more than 0.9% local regional recurrence-free interval. Now, We also did a subset analysis according to the stratification variables, and the stratification variables here was type of surgery, lumpectomy, mastectomy, estrogen receptor, progesterone receptor status, HER2 status, PCR in the breast, yes or no, and adjuvant chemotherapy. And just to mention here, adjuvant chemotherapy was very uncommon because it wasn't a standard at the time that most of this time the trial was running. So only 1% of the patients had adjuvant chemotherapy. Let me go back one. And as you can see, none of these factors showed a significant interaction. So the effect of radiotherapy was the same irrespective of any of the stratification factors. But we also did a subset analysis, an exploratory subgroup analysis, looking at the age of the patient, the race of the patient, tumor subtype broken down by 4 subtypes, and then axillary surgery. In other words, sentinel biopsy or axillary dissection. And essentially, none of this was statistically significant except for tumor subtype. For tumor subtype, we see a significant interaction. As you can see, let me see here. It's hard to point here, but anyways, oops. Right down there. So what you see here is that for patients that had triple-negative disease, the hazard ratio was on the opposite direction, like 2.3, which means that they had twice as many recurrences if they received radiation than even if they did not. We'll talk about that. It's a little bit of something we cannot explain. On the opposite side, if they were ER positive and HER2 negative, the hazard ratio was 0.41, so there was about a 60% reduction with radiation for that subgroup that barely was statistically significant, as you can see. And then if they were HER2 positive, they're essentially pretty much in the middle, so there wasn't much evidence of benefit in this one. So we'll talk a little bit more about that in a minute. So what we concluded at the point of the presentation and publication is that in patients who presented with biopsy-proven axillary node involvement and they converted the nodes to negative at the time of surgery, chest wall irradiation, regional node irradiation after mastectomy, or whole breast radiation plus regional node irradiation after lumpectomy did not improve any of the outcomes that you can see here. These findings, I think, suggest that downstaging involved axillary nodes with neoadjuvant chemotherapy can optimize adjuvant radiotherapy use without adversely affecting their oncologic outcomes. And obviously, more follow-up is needed because we have seen in previous studies that sometimes the outcomes change with much longer follow-up. So let's put a little bit the results of the study in perspective, and then Jean will make some comments on that later on as well. Now, it's important to note that like when you do every trial, by the time you report the results, the standards of care have changed. And this is true also for B-51 when it comes to systemic therapy. At the latter part of the accrual of the study, and since the completion of the accrual of the study, several things have changed. For example, in 2017, post-neoadjuvant capecitabine was introduced for patients with residual disease. Particularly, the benefit was shown for triple-negative breast cancer patients. In 2018, neoadjuvant carboplatin was added to the regimen, as I mentioned earlier today. In 2019, post-neoadjuvant T-DM1 was used for HER2-positive patients that have residual disease. Now you can say, well, in the B-51, the patients converted the nodes to negative, so they didn't have residual disease, but they could have residual disease in the breast. That's why I mentioned this. And then, of course, in 2020-21, neoadjuvant pembrolizumab was approved for triple-negative breast cancer. And then 21 and then 24, adjuvant CDK4/6 inhibitors, abemaciclib and ribociclib, were approved. And some of the patients in these trials had neoadjuvant therapy, had residual disease, and received these drugs. In 2022, adjuvant olaparib for early-stage breast cancer with BRCA mutations was approved, showing survival benefits. So all these changes will, number one, increase the number of patients that have PCR and may benefit from emission of regional nodal radiation, but also will improve the outcomes for patients that have residual disease, make potentially the locoregional treatment less important. Now, what about the exploratory analysis by subtype? And again, the results have to be interpreted with caution because about 20% of each subtype is represented in this analysis, and they're wide confidence intervals. So it may be a little bit of noise that can correct itself with more events. We have to wait and see. Now, for the triple-negative breast cancer patients, it's really hard to explain why the RNI group had more recurrences. It may be spurious. It may be just because only 20% of the patients were there. Maybe related to an immune suppression effect. It's very hard to explain why those patients did worse. We know from the Danish trials, the post-mastectomy trials, that the triple-negative subtype did not have as much benefit in terms of reduction in local recurrence, and there was no survival benefit. So it's possible that this subtype is more resistant to radiotherapy. And what I can say, it's unlikely that the benefit will appear with more follow-up in these patients because the recurrence pattern essentially spans about 5 years. After 5 to 6 years, triple-negative breast cancer patients do not recur. The majority of the patients have gone more than 5 years in B-51, and the minimum follow-up was at least 3 years. So we passed pretty much the curve. So we'll see, but I don't expect that the results will change. Now, for the hormone receptor positive and HER2 negative cohort, we'll have to be more cautious, and clearly more follow-up is needed for this group, given that the patterns of failure show persistent rates of recurrence, of late recurrence. Although technically, most of the local regional recurrences occur within the first 7 to 8 years. There was more benefit for post-mastectomy radiotherapy in the Danish trials for the hormone receptor positive, HER2 negative patients. Clearly, more local recurrence reduction and more survival benefit. So it's possible that this group benefits more. Overall, this group has lower PCR rates, and this is important because hormone receptor positive, HER2 negative patients with residual disease in the breast after neoadjuvant chemotherapy are probably more likely to have also axillary metastases. And of course, here is where the accuracy of sentinel lymph node biopsy and targeted dissection is important. Because if you have high probability of having residual disease, the false negative rate translates in more chance that you left a node behind that was positive, but you took out the sentinel node and you call it negative. So we have to be careful about how we assess the axilla, particularly for this subgroup of patients, because you don't want to misclassify patients and omitting radiation. So in summary, I showed you that neoadjuvant chemotherapy has allowed for de-escalation of surgical therapy in the breast and the axilla. This de-escalation has occurred to a greater degree for triple-negative and HER2 positive patients, but also in select hormone receptor positive HER2 negative patients. De-escalation of regional nodal radiotherapy based on response to axillary lymph nodes to neoadjuvant chemotherapy is oncologically safe, and I think this represents a major paradigm change. And for patients with triple-negative breast cancer and HER2-positive breast cancer, by individualizing post-neoadjuvant systemic therapy based on PCR, patient outcomes can be improved over the traditional adjuvant approach. So neoadjuvant chemotherapy actually can improve outcomes because you have the ability to customize systemic therapy while you de-escalate local regional therapy. And with that, I'll thank you very much for your attention.
Okay. So thank you, Dr. Mamounas, for a tremendous presentation of the background for the use of preoperative systemic therapy and the use of response to preoperative systemic therapy to help us tailor radiation therapy decisions and our focus here on the B-51 study. Yesterday, I gave a talk about the de-escalation of radiation therapy in low-risk breast cancer, and this is sort of the follow-on of that, looking at the de-escalation of radiation therapy in a more locally advanced node-positive population. And I like Dr. Mamounas' framing of not just de-escalating, but also customizing and using the response to preoperative systemic therapy to help us make the best radiation therapy recommendation for our patients. So Dr. Mamounas' presentation was very thorough. I'm not going to add a lot of data, but I will just share a few of my perspectives from the point of view of a radiation oncologist. So the first thing is just to summarize the results that Dr. Mamounas just shared. These are pretty impressive results. We can see that the NSABP B-51 study was an extremely carefully designed and well carried out study. And these results are very, very impressive. These lines are virtually superimposed. With the perspective of the primary endpoint of the study, which was invasive breast cancer recurrence-free interval, there was really no improvement with the addition of regional lymph node radiation therapy. And similarly, when we look at the secondary endpoints that were measured, local regional survival, disease-free survival, overall survival, also no improvement with the addition of radiation therapy. So again, these are very, very clear results in terms of the outcome of the study. At the same time, it is very, very important that we get this right. I think Dr. Mamounas did an excellent job in demonstrating that in the scenario of patients who have upfront surgery, we have seen from the EORTC 22922 study and the MA20 study that I shared a little bit yesterday, that radiation therapy does have the potential to impact disease-free survival in patients where it's appropriately applied. So if we're looking at making a decision to omit regional lymph node radiation therapy, the stakes are very high. We don't want to get this wrong. So we don't want to just blindly apply the results of B-51 to every patient. We want to think very carefully to whom can we apply these results, because we don't want to get this wrong. I think I'll take a moment here to comment on Dr. Mamounas' discussion about the false negative rate of a sentinel lymph node biopsy versus the risk of an actual axillary recurrence. And one of the strongest arguments that is often made for not worrying about residual disease in the axilla is that we find very, very low rates of actual axillary recurrences in most of these studies. But the EORTC 22922 and MA20 studies suggest that we may be preventing distant spread of disease even if we're not preventing direct axillary or regional recurrences, suggesting that the mechanism of benefit of radiation therapy could be addressing microscopic disease that may never progress regionally, but may seed metastatic disease down the line. So focusing really on getting the interpretation of whether the lymph node has responded or not is more important to me than focusing on just the axillary recurrence for these reasons. So when I have a patient who has had a nodal response to preoperative systemic therapy, and I think, should I be applying the results of B-51, I really go through very carefully and think about the eligibility of the patient for the B-51 study, and then also think about, were they treated in a manner that was similar to the B-51 study. So first, just highlighting the eligibility that patients were between T1 and T3 clinically, so patients with T4 disease were not included. So generally speaking, I would recommend whatever I would have recommended up front for patients with T4 disease, and then also clinical N1, but not clinical N2 or N3. Dr. Mamounas also highlighted the kind of challenges that we sometimes face in defining clinical N1. In the current days of having excellent imaging, we often are able to literally count the number of lymph nodes that we see on a PET scan or on an ultrasound or on an MRI. But for the purposes of enrollment in this study, clinical N1 just simply means palpable nodes that are not fixed or matted. So it doesn't have to do with the number of lymph nodes, as Dr. Mamounas said. But I do think it's important to consider the anatomic extent of the lymph nodes, because N3 disease, for example, would include periclavicular or internal mammary lymph node, and those are often identified on imaging. So I do factor in not just the clinical stage, but the extent of nodal involvement at the beginning of their diagnosis. With respect to systemic therapy, Dr. Mamounas already pointed out that there have been some changes, in particular in the triple negative subset of patients where we would now include immunotherapy. So I'll comment a little bit on that further. I think the importance of determining the response to systemic therapy in terms of the accuracy of the lymph node biopsy is probably more important than the details of the upfront systemic therapy, in that if the PCR is achieved, then that's the piece of information that we need to know. We are likely to see some changes in preoperative treatment for HER2 positive breast cancer. There was a presentation of the COMPASS PCR study at ASCO this year. Will be published soon, looking at some de-escalation of chemotherapy for HER2 positive patients, but without a change in the rate of pathologic complete response. So while I think it's important to make sure that a patient received modern and correct preoperative systemic therapy, ultimately, if the pathologic response is achieved, one could argue that that's the important result. And then finally, the surgery, really the importance of the sentinel lymph node biopsy. In the B-51 study, as Dr. Mamounas pointed out, the requirement was for a sentinel lymph node biopsy alone that 2 or more nodes are retrieved. So we'll come back to looking at that. Okay, so I think I've actually said these comments. Sorry about that. I want to come back to the surgery. So Dr. Mamounas presented the studies that sort of established the use of sentinel lymph node biopsy after preoperative systemic therapy for patients who present with lymph node positive disease. And he convincingly showed us that many of the studies that brought us to this place where we can now not do an axillary dissection, which is a tremendous benefit for the patient, but rely on the sentinel lymph node biopsy, found a much lower false negative rate when 3 or more positive sentinel lymph nodes were taken. And again, the B-51 study only required 2 positive lymph nodes. There are many other factors that will contribute to the reliability of the sentinel lymph node biopsy. Dr. Mamounas already pointed out that having a previous sentinel lymph node biopsy can certainly decrease the sensitivity. So we have sort of moved away from patients having pre-chemo sentinel lymph node biopsies. But in addition to the number of lymph nodes that are removed, we also have the mechanism of identifying those, whether we used radiocolloid and blue dye, whether ITCs are considered positive. If ITCs are considered positive, then it actually does increase the sensitivity or decrease the false negative of the sentinel lymph node biopsy. And in the B-51 study, ITCs were allowed. Axillary dissection was not required if ITCs were present. And then also looking at imaging and the use of the clipped node. So as a radiation oncologist, I think the most important thing that we need to evaluate in our patients that come to us is how reliable is this sentinel lymph node biopsy that was done. Certainly a minimum of 2 lymph nodes must have been retrieved to be sort of in line with the B-51 study. But I also do evaluate just all of these other factors to make sure that I am confident that it is a reliable sentinel lymph node biopsy. Dr. Mamounas talked about the discordance between the PCR in the breast versus the lymph nodes in about 20% of the patients that were enrolled on B-51. So 80% had a complete pathologic response, including the breast. For those patients who had a response in the nodes but not in the breast, those are the patients where it's particularly important to evaluate the quality of the sentinel lymph node biopsy, because we might worry a little bit more that there could be disease in the nodes that we simply didn't detect due to that discordance. So I think this is one of the most important jobs that we have as radiation oncologists, is to say, should we apply the B-51 study to our patient and consider the quality of the nodal biopsy? So just to review the subset analysis, we saw that the factors shown on this slide really did not have any relationship to the primary endpoint, but it was the tumor subtype that was actually suggestive of a relationship. Now, remembering that this was an exploratory analysis, so this is not something that we would conclusively declare that the results are different by tumor subtype, but they are certainly thought-provoking, and I think as we go through looking at each patient, we would consider the tumor subtype one of the most important characteristics of whether we apply these B-51 results. So let's go through these case by case. For the triple negative, this is the subgroup where it appeared that there was the least benefit to regional lymph node radiation therapy and potentially even bordering on a detriment. Again, just as Dr. Mamounas said, there's really no clear explanation for this. I agree with him that it's really unlikely to change even with longer follow-up, given the early recurrence pattern that we see with triple negative patients. I think it is important to consider that our patients today are more likely to have received immunotherapy because one of the possible explanations for why triple negative patients could have had worse outcomes with radiation could be some interaction between radiotherapy and immune suppression. And it's possible that the addition of immunotherapy could play into that. I don't know how, but it's just simply an important factor for us to be aware of. So triple negative is a very difficult one. I'll say a few more words on it in a moment. But I do think that those results are less likely to change with longer follow-up. The ER positive, HER2 negative, those are the patients where I think we are in agreement that we really need longer term follow-up before we would firmly apply these results, because these are the patients who are going to have a much later recurrence pattern. Also, these patients are probably less likely to be getting preoperative systemic therapy because we see a lower response rate across the board. But for those that do receive it, I think we need to wait for longer follow-up, and also where there are going to be ongoing changes in systemic therapy with CDK4/6 inhibitors and other things that are going to change outcomes for these patients. The HER2 positive patients are those that were the best represented in the study. Taken together, over 50% of the patients in B-51 had HER2 positive disease. And I would say, just thinking about the recurrence pattern, the ER negative HER2 positive, much like triple negative, have an early recurrence pattern. So those results, I think, are likely to be relatively stable, whereas the ER positive are just like the ER positive HER2 negative, still at risk for late recurrences. So these are the factors that I sort of take into account. So putting all of this together, this is my and my institution's kind of perspective on how we consider patients after B-51. The ones where we are the most comfortable with applying the results and omitting regional lymph node radiation therapy are those, again, who we think were best represented in the study. ER negative, HER2 positive, because those were well represented and unlikely to have later recurrences. I do factor in the extent of node positive disease at presentation, as I commented earlier. We know from other studies that there is a relationship between presenting stage and outcomes. So if a patient was clinically node positive, but we see on imaging that they had internal mammary lymph nodes, or that they had, really bulky disease that just maybe was not fixed, that's something that I take into account. So lower volume, lower T stage, we saw there was a relatively small representation of T3 tumors, and then also pathologic complete response in the breast as well. And finally, age. Dr. Mamounas pointed out that there was a substantial enrollment of patients under 50, but we don't really know how many super young patients, like under 40, were enrolled. And so a super young age is still something that I consider a risk factor. So for these patients, I feel quite comfortable applying the results. For the patients on this list, these are ones where I think it's reasonable to apply the results, but we have more of a sort of multidisciplinary discussion. Triple negative disease just remains worrisome because of the overall risk of recurrence for this population. ER positive, we worry about late recurrences. And then, residual disease in the breast, younger age, and then more extensive disease. These are ones where I think we have to take case by case. And then finally, if they were not eligible for the study, basically T4, N2 or 3 at presentation, or residual node positive disease, certainly we would continue to proceed with standard, regional nodal radiation therapy. And I'll just close with this algorithm. I can't take credit for this algorithm. My colleague that I used to work with, who's now at the University of Minnesota, has put this together. But this just shows a nice sort of thought pathway for whether or not you would apply the results of the B-51 study, kind of taking into account many of the factors that we just discussed. I want to conclude by saying, first of all, I do think that the radiation oncologist perspective is still very important, and I would discourage avoiding a referral to radiation oncology for patients who have a PCR. I think there is a lot of nuance in applying the results, so it's important to have that multidisciplinary discussion. And the second thing that I would say, just following on my conversation yesterday, is that those patients who do have a very good response to preoperative systemic therapy are those that we are going to feel also comfortable applying moderate hypofractionation. So the shorter courses of 15 to potentially 20, but usually for this group, 15 to 16 radiation treatments. So a much shorter and less toxic course of treatment is available. So that's another factor in considering whether we want to offer our patients radiation therapy. So thank you very much. I will close there, and we can go to questions.